Maybe I start with one question. In view of the suboptimal local regional control that you all have shown, with up to 25% local relapses, for instance, in extrahepatic cholangiocarcinoma, and the very high R1 resection rate, you have shown almost 40% in your UK study. I'm wondering a little bit why not adjuvant radiation is more a topic. All the studies from Europe you have shown, Actica, Bilcap, Prodecia, they are all testing adjuvant chemotherapy. Any comment from you from the surgical viewpoint or from the molecular biology viewpoint? What is your opinion in an extrahepatic cholangiocarcinoma with risk factors?
Well, as I said, I think we, especially in young, they're very often young patients, they're fit, so we need to do something about the local recurrence rate. And if you look at the NCCN guidelines, they say consider external radiation therapy. So I think we should probably use it more. We're not used to it in Austria. Probably Thomas Grünberg is here. I don't know if he has any more other experiences, but I think, as I've shown and you've shown, local, there is clearly a patient group that recurs locally, first of all. Of course, later on they get distant recurrences, but I think we should be more aggressive also in the adjuvant treatment setting.
But not easy to identify a priori at this stage.
Yes,
yeah?
that's
okay.
difficult.
Okay, so John.
Yes, John, I just wanted to follow on your discussion about adjuvant therapy. What I guess we don't know from the adjuvant studies is the number of people who present for surgery and don't go on to study. And I just wondered, you showed a nice slide of where we're at with various adjuvant approaches, and of course part of those changes are the move to neoadjuvant therapy, so rectal cancer, gastric, liver mets and so on. I don't think you focus very much on the neoadjuvant setting, and I wondered, it sort of relates a bit to Florian's question of the high rate of R1 resections and so on, what your thoughts are around the role of neoadjuvant approaches.
I think there's a session about that this afternoon, looking at neoadjuvant approaches. What can I say? We've tried to start a neoadjuvant study in the UK. There's been a bit of surgical resistance. They don't want us to do it. But you're absolutely right. That is the next thing to happen. You could argue that actually the ideal study is standard treatment in a group of operable patients, and you look at the R1 rate as the outcome. I mean, that's a very simple and attractive design.
So if you could, just to follow on, if you could choose which direction to go in and it was up to you, would you go neoadjuvant or would you try and maximize adjuvant approaches? I think the studies are as they are. The Actica study is going to tell us the optimal adjuvant approach, and I think if some smaller studies, and they are happening, will tell us about the value of the neoadjuvant approach, and if it looks good, I'm sure it'll go that way.
So this was a provocative statement against surgery. They are resisting the neoadjuvant approaches. I see Thomas Grünberger at the microphone. Probably you want to respond to that.
No, I see nothing as an aggressive approach to the surgeon, because I like to work with people. But I would, first of all, it's right that we are trying to discuss this in the afternoon, the potential of neoadjuvant treatment. And just to start with this discussion, what would you give, or what did you want to give neoadjuvantly? Which treatment?
There's a UK study using cisgem as neoadjuvant.
Yeah, but you have 23% response rate. So, I mean, what is the fact of downsizing a tumor with 23% response rate in the palliative setting?
So it's probably true. We need something that works a bit better, but I mean, we all know that. The French, again, Julien would be able to tell you, maybe somebody else can, are doing an advanced disease FOLFIRINOX versus cisgem study, and I think if we were to wait for anything, I think we would wait for that outcome.
Very good.
Question for you, for the surgery. What about lymph node dissection? You saw us that is a prognostic factor. The oncologists, we want to know how many lymph nodes are positive. You go and you take out what is clinically positive, and or you do written everything.
So I'm probably more aggressive because I usually clear the lymph nodes down to the celiac trunk, the right side of the celiac trunk, because otherwise you have high morbidity, and you won't add, as this one paper showed clearly, you won't add any survival benefit if one node is positive. Then, exactly. So it's probably, that's why many do not do an aggressive lymphadenectomy. So this is what I do, and it's, again, the guidelines say that you should do a local lymphadenectomy, just for prognosis.
But local, if you have only one lymph node clinically, that doesn't mean that you only one lymph node get out of the tumor, because we have a lot of times we've seen our reports, pathologic reports, like in 0, 1 out of 2 or of one lymph node.
That's right. So the recommendation says you should at least dissect 3. And you have to go further if you want to have more. It's easier probably for the pathologists to find more lymph nodes if they are jaundiced and they have a biliary stenting, because then you have reaction, and I think it's easier for them to find them. But I think you need to go further if you want to have proper numbers of lymph nodes. But be careful, because if you do too much, the morbidity is increasing. And you don't want to, I mean, it also depends on the sites of the lymph nodes, because usually, I know some centers from India, for example, they have loads of these patients, so they go in and they dissect the lymph node, which is behind the cava, in front of the cava and behind the pancreas, and if this one is positive, then they stop the operation, because they say it doesn't make any sense to resect the patient any further.
Thank you.
Thank you. We have another question from Markus Möder.
Thank you very much for the great talks. I would like to address again the molecular differences between intra and extrahepatic cholangiocarcinomas. In the recent years, we discussed also palliative chemotherapies like targeted agents. I like the idea of the stem cells and the differentiation. However, we have tried to use c-Met inhibition. We tested Herceptin, we tested EGFR1 blockade. But I missed all these signaling pathways. Is that not of importance anymore? So what is the role of these typical, classical, also angiogenesis? So is there still a role on these signaling pathways?
It's a very complicated question, I think, because we have to distinguish 2 types of alteration. First, the activation of the pathway without clear genetic defect that could be targeted. And most of the time, we didn't know if the cells has oncogenic addiction to this activated pathway, such as EGFR pathway in cholangiocarcinoma. So maybe we have target the wrong target using biotherapy, and we need to identify which genetic alteration is an oncogenic driver. It's not very easy to do, because, as you know, an oncogenic driver could be targeted easily, like the BRAF inhibitor in melanoma, but not easily in other subtype of tumors. So if we have to deal with histological context, with what we know about the genetic alteration, the frequency of the genetic alteration, and the preclinical model. And I think the best candidates are the most recurrent genetic alteration in the subtype, and not only the activation of the pathway without the genetic defect at the genomic level. But we didn't know if FGFR2 inhibition will work properly. There are some preliminary data that say that there are stable disease and not a clear response in this tumor. So we need more data, more patients that we treated by FGFR2 inhibitor or EDH1 and 2 inhibitor. And as you say, as I described, IDH1 and 2 inhibitor induce cell differentiation in vitro model. It's not clear if inducing cell differentiation is sufficient to clearly eradicate the cancer.
Thank you very much to all of you for the discussion. Thanks again to the speakers for their excellent talks. We will now clear the podium for